In general, I would not sequence ADC back to back.
For a patient who's doing really well on T-DXd plus P, so the DB09 regimen, would you consider just continuing therapy until progression, or would you consider otherwise, like a maintenance strategy?
In general, if the patient is tolerating the therapy very well, you could continue. But if there are side effects, then one could switch to maintenance strategy. So that's something that's more driven by patient experience and discussion in terms of the side effect. In terms of a patient who has complete response or complete remission, at some point, should you stop T-DXd? I think that's an open question. It's similar to HP. Here and there, we do have patients who have no evidence of disease or complete response. And then should you stop HP or should you continue HP? I think these are open questions.
Absolutely. The hope is that, using T-DXd plus P in the first line will get more of these complete responses and long-term remissions. So sequencing after DB09, what comes after your first-line therapy with DB09 regimen?
When a new therapy displaces first line, that becomes second line. So if a patient is on T-DXd and continues T-DXd and then has disease progression, one option to consider would be THP in the second line setting. And then the other options remain. One could use capecitabine plus tucatinib. One could use TDM1. In general, I would not sequence ADC back to back just because we have other options available. So I would personally either consider capecitabine, tucatinib, or would consider THP. Some of these patients will have disease progression because of brain mets. Definitely in that setting, I would consider capecitabine plus tucatinib.
That's very helpful for us sort of taking this data home. Some folks feel that, using T-DXd in the first-line setting is sort of burning through an option. Do you look at this as an opportunity for patients or a barrier to later-line therapy?
No, I think in general, oncology, we use our most effective drugs because what if you have a complete response or remission?
Absolutely.
You might not get to a second line. So, as long as a drug is active and patient meets criteria, in general, it's good to use that drug. If a patient has disease progression T-DXd, then you can use a second drug, a third drug, and that's how we prolong overall survival.
Sure, and these other drugs, should have some efficacy, although maybe not as, profound as in the first line setting, correct?
Correct.
Yeah. And then you mentioned, getting to that second line. As we discussed early on, some patients don't make it to second line, so using that best therapy up front does make sense.
It's a good point.
Do you see any practices with adoption of, newer regimens such as DB09? Do you see any regional patterns, maybe reticence or hesitant to adopt a new therapy?
I'm not seeing any data related to regional practices, but I can imagine if a physician is not very comfortable with T-DXd and has a lot of experience with THP, they might start with THP, reserving T-DXd for the second line. But someone who has experience would potentially consider it in the first line. Now, in the future, we'll have other drugs as well, tucatinib or CDK4/6 inhibitors like palbociclib, and that might further complicate in terms of how these drugs are being used.
Are there any misconceptions you hear about T-DXd and its ability to be used or safety in patients?
ILD, I think there's appropriate concern related to ILD, but it's not at a level where T-DXd should not be used. And the other is this idea that you necessarily have to continue T-DXd forever. If a patient is having side effects, you can consider dose reduction. You can even switch from T-DXd to HP maintenance. That's better than discontinuing the therapy completely.